off track, you can just stop me and like redirect me. Is no problem at all. And I'll definitely try to be done in 20 to 30 minutes. So don't let me go too long. All right, I'm trying to go to the next slide. It's not letting me do that for some reason. Down here, maybe. Okay, perfect. All right, so this is my outline. I'll define what a port wine birthmark is, go through some subtypes, some syndromes, and then evaluation and treatment. I'm going to go through all the subtypes and all the syndromes. So if it goes way too in the woods, again, just wave at me, Julia. I'm 100% not embarrassed.
You got it.
Cool. Definition and classification. So what is a port wine birthmark? So it's a type of capillary malformation. So it's a red spot that you're born with that blanches with pressure. That's kind of how I know it. And then if you biopsy it, it has increased blood vessels, so increased small capillaries, and post-capillary venules. So it's the part right after the artery, and then the part a little bit after that, just before it goes into veins. In the forehead, they tend to be all on the very top layer, the papillary dermis. On the lower face, they tend to be on the top layer plus in the reticular dermis, a little bit lower in the skin where the sweat glands are. And those also tend to be more resistant where they're a little bit lower. And then people have also tried to give like formal definitions. So here's the most formal definition I could find from from Pediatrics: a congenital simple malformation of capillaries or post-capillary venules. So what does that mean? Congenital, you're born with it. Simple, it's just one structure, just capillaries. And there it is, of capillaries or / post-capillary venules. And then older people who have these birthmarks recognize the post-capillary venules as the blebs they get as they get older. So those after capillary vein part can kind of swell up a little bit and turn to more purple. Classification, another way to look at it. So one way is there's something called a hemangioma. So that's one thing that grows and shrinks over time, versus something called a malformation that you tend to get born with, and then it just kind of stays the same size. Or another way to look at it is it tends to grow with you. So kind of if you have a balloon, you draw a dot on it and then you blow it up, that dot kind of grows with the balloon. That would be a malformation. And then within that malformation group, it can be made of capillaries, veins, lymphatics, or arteries. But of course, if you're an artery, there's always a vein along with it. So they call it arteriovenous. And then there's the tumor versus malformation. Oh, 1 second, we have a problem. What's the problem, big guy? Oh, that's fine. I'll just save this for myself. Thanks, big guy. All right. Sorry. Vascular anomalies. All right. So one more way to just kind of beat this dead horse. You got your malformations and you have your tumors. Malformations are the capillary malformation, venous, blah, blah, blah. And tumors are things that kind of grow. And then the last slide here, just in case you guys want to double check me on that, the best way to get the best classification for what you have is this ISVA classification, ISSVA. And you can Google that term, ISVA classification, and then you can find capillary malformation and learn about exactly how we classify things. It's a very, very nice resource for knowing exactly if you have the right thing. All right, so I guess I'm like really pushing this horse and beating this dead horse. So 2 ways you can define a port wine birthmark. So you have a capillary malformation. Some people will say anything that's a capillary malformation can be called a port wine birthmark. But some people are more splitters and they'll say only if it's on the head and neck can it be a port wine birthmark, and it might be associated with Sturge-Weber syndrome. So capillary malformation, no matter what. I tend to be a lumper, but it's good to know both. All right, next topic we have is the subtypes. So subtypes of capillary malformations. So here's a nice chart. Has all the different things it could be besides just a port wine birthmark. And I'll kind of walk us through each of these slowly. And then if Julia or Karen wants these things, like you ski these slides, of course, if people out there want these slides, because I'm going to go through it fast to make sure it's 20 minutes. So first thing, Nevus Simplex. So here's a Nevus Simplex. This is like probably a very common consult for us in pediatric dermatology. Is it a Nevus Simplex or is it a port wine stain? So the Nevus Simplex is also known as the angel kiss. It looks like you got smooched. And this one tends to fade over time, and it's not associated with anything. How do I determine if it is just a little birthmark that's going to go away? I look at the shape of it. If it's on a V on the forehead, that helps me out. And then this kind of symmetry to it, where it's on the upper eyelids, and then it goes down to the philtrum right there. Those help me out a lot. If they have a little stork bite, a little red spot behind the neck, and they have that little butterfly on their lower back, that can be helpful as well. And that is not a port wine birthmark, of course, because it goes away. It's not recommended to laser it because it's going to go away. Next thing that we'll go over is exactly what the main thing I'm here for, port wine birthmarks. And some people will classify geographic stains within the same group. So well-defined red spots, port wine birthmark on the face. If it's on the body, you might call it a geographic stain instead if you want to be a splitter. And there's what we all recognize, the well-defined red to pink spot, might be a little bit purple, especially as you get older, on the face. And they can be in those different segments of the face, the forehead, cheek, chin, or a combination of them. And then how do I distinguish that? Solid to red. It's same size from young age, it's on the head and neck. So just like we all know. Or geographic stain, happens to be on the leg. These tend to get more of those purple blebs earlier in life than the ones that you have on the head and neck. Same thing, geographic, you can try to draw a line around it and it might get little blebs, but especially earlier in life. And then we go to some other non-port wine birthmark things. You might have a reticulated capillary malformation or a cutis marmorata telangiectatica congenita. Woo, let's just call it CMTC, okay? So here's a reticular port wine stain. So this is not a port wine stain, but some kids on their extremity will have like a network type pattern of pink, and that same leg might be slightly thicker than the other leg. It'll feel a little wider. That's typically a reticulated capillary malformation. But what if you feel that leg and it feels smaller? We've got a name for that. So that would be CMTC, that cutis marmorata telangiectatica congenita, the fancy word, but the leg is a bit smaller. This one tends to fade over time. The legs tend to improve. The reticulated port wine stain tends to kind of stick around for a little bit. And our last one second to last one within this category is the capillary malformation, arteriovenous malformation. This would be the one that's kind of dangerous to make a mistake for. So you think you have a port wine birthmark, but it's actually this thing. So what is that? So this is actually like capillaries in the arteries. It's the other side. So it's not capillaries in the post-capillary venule. It's more capillaries in earlier on the artery thing. Sorry, you guys, I am babysitting my kids today too. So this is Paxton. So thanks. And then the way I kind of look at these is one is multifocal. So I have lots of little red spots, and they usually have like a little white halo around it. So your typical port wine birthmark will be just the geographic stain that you can draw around it. But if it also has a little white halo, you might want to feel it. And if you feel it and it feels really warm compared to the other skin, it might have some extra blood flow in there that's a little bit heavier than other spots. It might be this capillary malformation, arteriovenous malformation syndrome. Good to know, because instead of the malformation in the brain, you might get arteriovenous malformations anywhere with this one. And this tends to be autosomal dominant. So if you have a family history of lots of people with arteriovenous malformations, and then your child comes out with this, you'd have a little heads up to give your doctor there or your team. And the last one, telangiectasias. These are what all of us, when we get in old age and our legs and stuff, have these little dots with little red lines around them, or people, if they're pregnant, they can get these on their body as well. Papule or red spot with little radiating vessels. Telangiectasia, definitely not a port wine birthmark. Okay, so we did definition, subtypes. Let's do some syndromes. Syndromes. So here's some syndromes associated. Also a big chart, which you can find on ISVA, that website I told you, www.issva.org, if you ever wanted to check in on this stuff. So that's a busy slide. Let's kind of simplify it to the way I think about it. So when I see people with a red spot on their body, I think they could be in one of three categories of syndromes that would fit in those charts. So you could be in the GNAC group, which is the Sturge-Weber group. So you have a red spot and proportionate overgrowth. If you have overgrowth, it's your whole leg is proportionally enlarged. It's not one finger is way bigger than the other, and that sort of thing. If you have disproportionate overgrowth, so some fingers are way bigger than others, and they're all involved, it's just kind of really disorganized, you might have something down this PIK3CA pathway. So it might be a PIK3A syndrome, Proteus syndrome, tuberous sclerosis, but probably not in the Sturge-Weber group. And then the last group is your RAF-MAP kinase pathway on the far right. So in this group, you tend to get new lesions over time. So it's not like your port wine stain you're born with, like Sturge-Weber. This is more like you have it, and then you got two, you got another couple spots, and then down the road you get more. Then you might have something in this capillary malformation AVM syndrome category. And I'll kind of slowly go through those for you, so you can kind of get an overview. So here's that PIK3C3A pathway, the mTOR pathway. What's also important to know about the mTOR pathway is these people respond really well to rapamycin. So a lot of people with Sturge-Weber ask me about, can I use rapamycin on their birthmark? Sure, of course. And sometimes it works, sometimes it doesn't. If it works really well, maybe you have one of these syndromes or a different mutation. Don't touch my stuff. All right. So here's the PIK3CA related overgrowth spectrum. I'll go through it just briefly. So you tend to have a capillary malformation, another type of vascular malformation, like a venous malformation, and then that abnormal overgrowth. It might be like lipomas. It might be your hands are extra large, or it might be overgrowth of your skin. You have epidermal nevi, but that'd be it. So capillary malformation, another vascular malformation, and another type of overgrowth. And here's some examples. So Klippert-Tonani is included in the PIK3CA related overgrowth spectrum. So they got the capillary malformation, the venous malformation, and then they have the overgrowth. But there's others in that group as well. And I just repeated that again. And another thing about the PIK3CA is this, if it's more peripheral type stuff, like I talked about the larger hands and feet, that helps you out too. There's some names for what we have on the screen there. And then if you have people in that group, this is like who they are. And sirolimus works really well for these. That's the point of this. So if you have in that spectrum, you might want to try either topical sirolimus or drinking it. All right, GNAC syndromes. Let's circle those, Sturge-Weber, and then there's something called limb capillary malformation with non-progressive limb overgrowth. So kind of like that reticular port wine stain that I showed you earlier. So it's a stain, your limb is a little bit wider, but it doesn't keep progressing. It's not a progressive disease. And then the last one actually is another fancy word, phakomatosis pigmentovascularis, also has GNAC. So that would be red stain, blue spot, and you do a biopsy and send it over for genetic testing. You have a GNAC mutation. So let's start with Sturge-Weber. Here it is. This is what you guys all know better than me, especially at these lectures. I'm not going to say anymore. And then the at-risk areas, forehead area, and the scary one is that median one. That's the one where I might miss a Nevus Simplex, that little angel kiss, or the Sturge-Weber syndrome. That's the one that keeps me up. Phakomatosis pigmentovascularis type 2 could also be Sturge-Weber, plus you have some blue spots. You have some dermal melanocytosis. That's what the name of those blue spots are. So here's a kid that has that. So he has a red spot, the blue spots, and look at that. He has the malformation in the brain too. So they did some genetic testing. He has a GNAC mutation. What's interesting is when you do pulse dye laser on these kids, so blue spots are only supposed to respond to tattoo lasers. But for this syndrome, they'll also respond to pulse dye laser, just like lots of Sturge-Weber spots do. So it's kind of interesting. It's not targeting the blue, it just works. There you go. And that's a Burkhart rule, Burkhart experience rule. So, but I've had other friends tell me the same thing. So actually, going back to that, I have had some patients that have this ask me to pulse dye laser their blue spots at the same time as I treat their red stains when they're asleep or whatever. And as long as they wait 6 months, they will see that result. It does happen. All right, and then the RAS-RAF MAP kinase pathway, the capillary malformation AVM syndrome pathway. So here's all the fancy words. I'll go over the first two of them. I won't go over all of them. Put them on the chart again, just proving that I did the whole chart for you. Capillary malformation AVM syndrome. So it's oval, they have the peripheral halo, multifocal, and you tend to get more over time. Those are your clues. So look at that, multifocal. That doesn't look like your typical patient with Sturge-Weber syndrome. You have these spots that kind of get more over time. And then maybe you do an MRI, MRA, and those arteries are not, are all, there's too many there in that left leg compared to that right leg. So my workup and treatment, the big thing is genetic testing. So if you have an overgrowth with your red spot and you think it might be one of those PIK3CA mutations, then I think it's very worthwhile to do a biopsy from an affected area and send it off to be tested. It's usually in the macrocephaly syndrome group at like whatever genetic company you use. And the importance of that to me is if you are positive for PIK3CA and not GNAC, then I think it's reasonable to offer sirolimus as a systemic therapy to prevent progression. If it shows GNAC, I don't think it's going to help you very much. And so I wouldn't think the risk-benefit ratio is there for you. Another thing that helps me with determining the worthwhileness of genetic testing, if you have red spots plus blue spots, especially if they're overlapping, you probably have a GNAC mutation. And then if it feels warm and it has the peripheral blanching, like I told you that the cutaneous malformation AVM syndrome, it feels really hot. You would do a different mutation pathway, this RASopathy pathway, they call it. Imaging. So yeah, I'm sure you had somebody talk to you about imaging already. And that's for your Sturge-Weber imaging. However, maybe you're worried about, the second bullet point is maybe you're worried about, it's actually an arteriovenous malformation. Usually you start with a ultrasound. If it shows evidence of fast flow, then you might want to do an MRI. And then the laser stuff, you might want to delay that. And then some more overgrowth type protocols there. Medical intervention. So if you have one of those, as we said multiple times, you have the PIK3CA mutation disorders, the mTOR pathway. So maybe you have tuberous sclerosis and you have a port wine stain. Yep, sirolimus might work as a medical intervention. If you have things in that RAS-RAF MAP kinase pathway, those MEK inhibitors might work. But I don't know of any perfect medication for GNAC pathway right now. Maybe Julia or Karen do, but I do not. And then, so treatment tends to be, from my end, lasers. Pulse dye lasers are favorite. So that is a yellow laser. And so the importance of yellow and red light is those are the ones that penetrate the deepest and get to the vessels you need to the deep end. So if I have a flashlight and I put it through my finger, I don't know if you can see on the screen, I'll have to see if I can see myself, but it should show that my finger is red. Red light penetrates, and it might be a little bit yellow too. Yellow penetrates a little bit too. So all of your red and yellow lasers are the ones that you tend to use. Blue lasers would not work. All right, and then pulse dye laser tends to be the most common. I'll do the general overview of what you do for that. So the general principles to pulse dye laser for port wine birthmarks is we generally recommend starting the first month of life, at least because you want to have to try to avoid general anesthesia for your child. It's probably okay to start later, but then the later you go, the more scary it will be, the more likely you'll need general anesthesia in those first years of life. We like to treat every 1 to 2 months. Some people do as fast as every 2 weeks. But it's not a critical thing that you come in every 1 to 2 months. You can do things like take breaks during the summertime or whatnot. You don't have to be strict about it. After 1 year of age, consider going to sleep instead of doing awake to make your other pediatric appointments better. So yes, you can do the hold down the whole way through. However, just realize it might not just affect, it might not just be that appointment is affecting. It might affect your appointments with your pediatrician too, if they start getting afraid of doctors. So you have to weigh that with your decision making. Expect fading which can be significant, but not complete removal, and then expect it not to be permanent. And then this is what I did with Julia and Karen. We did a study with people across the nation. Thank you for getting access to all that. And what we found is I felt like our hot spot was somewhere around 20 treatments tends to be where people start to plateau in terms of becoming more and more happy with their laser treatments. So if you start getting into the 50 to 100 group, don't expect to be much happier with what you got. So a lot of us in dermatology feel like your first 4 treatments can tell you a lot about whether you're going to get significant fading or not much. And then once you hit number 20, you're pretty much about where you're going to be in terms of how satisfied you'll be with your birthmark. And then color match did seem to improve in our study, the more treatments you did. So you can't keep going. Your color match does improve as you go up, even though satisfaction wasn't there. But the flatness did not seem to change. We did see that it looks like if you start earlier with your pulse dye laser treatments, you likely have less overgrowth in the future than if you delayed your treatments till after age 2. Oh, we got chat buttons. Is it saying get over with this? Color match. Okay. Color match was up to the patients. So we asked patients, how was the color of your port wine stain match your normal skin? And that was what they decided. And then what is the risk of repeated anesthesia? Yep, and you do it 2 or 3 times a year. So the risk for anesthesia, unknown. So that this is something that's very, very personal dependent. So I've had some Sturge-Weber families tell me they like it because they feel it prevents seizures. And there's some evidence with, I feel the depression field, that sort of thing that might help. The biggest question is within those first 2 years of life, if you do repeated anesthesia, does that potentially increase your risk for ADHD and very small learning problems? So the general rule about surgery for us people that do elective procedures is if you can delay things or avoid anesthesia, do so. But if it is a significant, if you do have a good significant reason for doing it, go for it. That's about where that data is. I hope I answered your question. If not, just pop it out there again. And then older people, as I said, it turns to more purple. So you can use different lasers. So pulse dye lasers, like for kids, that's all day long. Once you get older, you get more veins, more deoxygenated blood, bigger vessels. So you might want to switch to hair removal lasers. Alexandrite laser and DIAG, those are the typical ones that people use. Intense pulse light, they tend to work better for older people, not so much for young people. And then I just put some laser complications just so if you've gone under tons of laser procedures, you're probably going to get a complication. And if you want to kind of know what was it that went wrong, this kind of gives you, because this is my guide, this is how I do it. If you see like little rings, probably a lot of us use like lasers that have a cryogen spray, like little white little rings. If I have my laser floating above the skin, I didn't put it down. So it's not just I put too much energy, I actually had it kind of raising up. You might get the dark spots that you see on the floating handpiece or failure to stay perpendicular. That means it didn't have the full spray, didn't get to the skin, and so it got too hot. And then if you have perfect circle white scars, yeah, I just did way too much energy. That's not too cool. See 2 chat questions. All right. In older children, do you think treatments are more effective with general anesthesia, or you can get the same quality by holding the child down? Yeah, so I do not. Anesthesia, I really personally don't feel it affects the treatment one way or the other. It's more about the preference of the child and the family. When you're under anesthesia, your blood pressure does go down a little bit, which can make your port wine stain fade a little bit. And so there's a little bit less target for the laser. So what we do when your child's asleep is we tend to shift the bed to have their head lower than the heart, and maybe ask the anesthesiologist to push on that little green, the balloon we always say to blow up. You kind of push on that to kind of make it kind of like the bearing down a little bit, and that kind of pulls some more oxygenated hemoglobin to the face, and that can help the laser work better. When the child's awake, if they're crying, I don't love that, but it does make the laser work better. It brings the pressure there, it brings more blood. that does help that.
There's another question. Have you seen any children have a seizure post-laser treatment if they were awake and not sedated?
I have not, never have. Julia, do you ever see that?
We haven't heard a lot about that, no. Now, I will say that what we have heard is that because sometimes when they come, if they're not feeling well or they're not at their best, right, their thresholds are down for other reasons, we might hear that, you know what I mean? Like if you're getting over being sick, you're doing all these other pieces.
Yes.
You know, because a lot of times we say it's only going to be, a couple minutes, those kinds of things. And you try, because they do get sick with school and school, those kinds of things. So that's one thing I've heard several times from parents, but we don't hear a lot of the other part now.
No, yeah, same here. It's good to hear. That's great. These are great questions to me. All right, so I'm just at the very end, I thought of some things that people that ask me about, like, what's my favorite sunscreen? So these are sunscreens made for people with Indian skin, black skin, Asian skin. So if you have a particularly dark port wine stain and you want to wear sunscreen, these are sunscreens that won't leave streaks. So you might be more accepting of it. For most of us white people, CeraVe AM facial moisturizing lotion is super popular. Or the Elta MD UV Clear SPF 46. Those tend to be the most popular for people with Caucasian skin, but these are all good ones for not leaving streaks. If you don't want to have that, you're probably older.
Can you repeat the ones for the white skin?
Yep. Elta MD UV Clear SPF 46. Woo, long name. Okay. I'm sorry. That's what my wife uses. That's great sunscreen.
Can you send that to us? Because I can send that out to the group too.
Yeah. I'll just give you I'll reply to your email, like one of your emails, and just give this whole lecture. Yeah.
You're awesome.
Then the CeraVe AM facial moisturizing lotion. It's not advertised as a sunscreen, but it is, and it's a really good one, and it treats pimples. So, and then moisturizers. So Vaseline, of course, Aquaphor, of course. But if you want to know some other options, you're like, I just want to do something other than Vaseline, and my spot's getting rashy. These are some of my favorites. In the eczema world, the Zero Calm is very popular, and they have some gentle washes. And you'll be getting these. And if you want to have the lowest allergy gentle cleanser, because you think because port wine stains can get little rashes occasionally, and you just want it to be something that's extra low allergy. These are very, very low allergy. Some of them more natural than others. Washes that you can use on your young children. These are for babies and toddlers. Faster bruise resolution. So some people want to have faster bruise resolution. I like, so Dermend. Oh, I see a question issue. Let me get that. Mineral sunscreens versus regular. Yeah, definitely. Mineral is considered the best. So all the chemical sunscreens, the regular ones, there's always worries about, are you absorbing some of it? Does it have some kind of hormone estrogen type effect? So the physical blockers tend to be safer in that effect. They don't have any of that. Zinc and titanium. The problem with the zinc and titanium is they can feel greasy. Oh, sorry. What did you say, Julia? Nothing. Oh.
No, that's perfect. Keep going. There's another question when you're done.
Okay. And then, oh yeah, what's the other question? Go for it.
After having treatments at a young age prior to 2 years old, with a very good effect, will the port wine stain become more apparent in the future?
I think they do become slowly more apparent, and they usually need touch-ups every several years. Some people are lucky; it's like in 10 years. But I feel most it's more like 3 to 4 years. What's your feeling, Julia?
We do hear it that that they do touch-ups. We haven't had to do that yet with Marissa. It's been a couple years already, so. But I don't know. I mean, I think everyone's so different.
Yes.
As what we find with everything else in Sturge-Weber.
Yes. Yeah. So it's not a major event where you have to do the whole series of 20 again. It's definitely not that. So Dermend moisturizing bruise formula, that's made for 80 and 90-year-olds to kind of remove the bruises on the backs of those arms. But anything that bruises, this is a great cream to make those bruises go faster. Yeah, just talk to your dermatology team if they're okay with that. Some people feel the bruise might feel that bruise is helpful to make your port wine stain go faster. I don't know. I don't feel it changes it. And then if you're getting a scar, these are my favorite scar prevention type treatments. if you think, so normally I recommend Vaseline after the treatments, but if you're like, oh gosh, I think I might get a scar, my favorite treatment is Biocorneum Advanced Scar Treatment. You can find that at Walmart, and it has SPF 30, it has a physical blocker, and it has silicone, so it has everything you need. Leaves like a nice little layer on the skin so you know it's there, but doesn't leave streaks. That's my favorite. But these other ones are also just as fine for helping prevent scars.